All right, so no disclosures. Oop. Just by way of introduction, we're talking today about opioids and opioids for common trauma and acute care operations. Opioids obviously are frequently prescribed. We know that that's a common thing, and we know that there are increasingly, we're sort of understanding the role that opioids play, safely prescribed opioids for surgical procedures play, specifically in the opioid crisis, that surgeons and people who prescribe opioids really do serve as sort of the initial contact for a lot of patients who go on to have chronic opioid use disorders. And one of the big questions that we've been asking as part of this program and that's being asked nationally is whether all the opioids that are prescribed are necessary. It seems increasingly as though that's not true, that many opioids are not used by the patients for their prescribed purpose, and that those diverted opioids that then get out into the community are actually a primary source of opioid misuse and a major nidus for that first opiate prescription that can then go on to chronic use, opioid use disorders, heroin, et cetera. With all of these sessions, we've been looking at a little bit of data from the Wisconsin Health Information Organization. And we do that through our work with the Surgical Collaborative of Wisconsin, who is our partner in this program. The Surgical Collaborative, through its collaboration with WIO, has access to this really remarkable database that actually is pretty unique to the state of Wisconsin, a database that's almost entirely comprehensive. It includes about 75% of the Wisconsin population. The only thing it misses is some Medicare fee-for-service, and it has excellent data about inpatient and outpatient use of medications, as well as pharmacy claims, so fills at pharmacies, unless they're paid for out of pocket, which we think is pretty uncommon, we capture in the WIO database. So it really gives us a good way to look at the opioid prescribing practices around a variety of diagnoses and procedures. And so Rhonda Cartmill, who's here with me today, is our sort of lead researcher. And she's put together this database where we look at opioid naive patients. For today's purposes, we looked at two common acute care surgery diagnoses. So outpatient laparoscopic appendectomies and laparoscopic cholecystectomies. The sort of specifics around how we do that, we look for patients with continuous insurance coverage for a minimum of 90 days before the procedure and 7 days after, including their prescription drug coverage. Looking at surgeons who performed 20 or more procedures in the study period, just so that we have some sense of, people who are established doing these procedures and have an established practice pattern. And then we limit ourselves to only those procedures. So if you had an incidental appendectomy, incidental cholecystectomy, or potentially getting opioids for something else, we've eliminated those. It is important to note that this data is not risk or reliability adjusted, but it does give you, I think, a pretty interesting sense of just the variation of practice that we see. So let's look at some of that quickly. So these are opioid prescriptions after laparoscopic appendectomy in, again, opioid naive patients by Wisconsin surgeons who do at least 20 appendectomies a year. So each of those vertical bars represents a surgeon. And it may be a little hard to tell, but there's a green bar here. And the green bar represents the maximum opioid dose that is suggested by OPEN, which is the Michigan equivalent of the Surgical Collaborative of Wisconsin. They've actually done a lot of work around best practices for opioid prescription. So this is morphine milligram equivalents. This is sort of a way of capturing the potency of a wide variety of medications that are prescribed. And as you can see, I mean, we're ranging anywhere from, under 50 MMEs, which would represent just a few, oxycodone, all the way up to 300 MMEs. And another thing that's interesting is we're seeing pretty significant variation even between providers around their prescription practices. Picture for laparoscopic cholecystectomy is similar. A few more surgeons out there doing a lot of cholecystectomies than doing a lot of appendectomies. But again, here's that green bar. and we know from what we've been able to determine from the open work and from a lot of published work is that laparoscopic cholecystectomies as a common procedure are often, are very well studied. And the vast majority of patients are using very small numbers of opiates after surgery for laparoscopic cholecystectomy. So with that, I'm going to just turn the table over to Dr. Jung to continue the discussion. So I'll load your talk up here. I should say, by the way, I don't know if I think I forgot to mention, I'm Jonathan Kohler. I run the SPOTS program. I'm a pediatric surgeon here at AFCH and run a lab that focuses on health communication and talking about best practices between providers. And Rondi, do you want to just introduce yourself?
I'm Rondi Cartmel. I'm a researcher and I work with Jonathan.
All right, take it away.
And that is the microphone, right? So
yes.
Just make sure that if at any point my audio is bad and I need to speak closer to the microphone, please let me know so I could adjust. Thank you guys so much for spending time with us today. And I'm sorry I was running a little bit late. I was running from our ATLS class that we have running at the same time today. So again, my apologies for running a little bit late. So my goal is to talk a little bit about trends in opioid use and persistent opioid use related to emergency general surgery and to trauma surgery in the adult population. I'm actually quite, those numbers that we just saw aren't great, but they're not terrible either. So I was pleasantly surprised by them. For reference, as you go through these numbers, and we'll present a lot of these things as MMEs. MMEs, if you see an MME number, basically you could divide them by 7.5, and that'll give you the number of 5 milligram oxycodone doses that a person would be getting. So on that high end, we were seeing about 40 tabs of oxycodone, which I think probably may be a familiar dose for a lot of people, but probably represents a prescription for opioid medication that's probably far too high now. So again, my name is Hee Soo Jung. I'm going to first start off with trauma. And these subjects, trauma and emergency general surgery, are a little tough to cover in terms of specific procedures, just because trauma and emergency general surgery really run the gamut of procedures, both minor and major, across the spectrum of the body. So I'm going to try to talk about a lot of these things in generalities rather than specifics about specific procedures. So as you all know, injury is a huge burden on society in terms of health. 39 million people are injured every year in the United States, and an estimated about 16% of injured patients become persistent opioid users after their injury. So this becomes a significant issue in the United States as it relates to opioid use and abuse. Adjusted for socioeconomic status and self-reported health, people who are injured are about 73% more likely than people who are not injured to become persistent opioid users. The things that impact persistent opioid use includes things like socioeconomic status, higher injury severity, older age, ICU admission. Non-Black race people are more likely to become persistent opioid users, prior opioid use, history, back pain histories, longer hospital stays, as well as a history of depression are all associated with higher rates. And as probably people have talked about throughout this series, prior opioid use is associated with worse outcomes after injury. So about 54%, about half of people who are admitted for injury diagnosis and are admitted and are discharged from the hospital receive an opioid prescription on discharge. People who are older, who are married and have a higher injury severity score, that's the score that determines how badly they're injured after in terms of the different organ systems. Those people are more likely to get opioid prescriptions. The surprising thing to me always was the marriage. I don't quite understand how that works, but I'm sure people can have some theories.
Someone advocating for you to go home with more pain medicine?
What's interesting, though, is that people post-injury who consume more opioids actually communicate a greater pain intensity and less satisfaction with their pain control after, mostly when they looked at this, was orthopedic trauma injuries. So it's actually, and this, obviously, it doesn't tell you, it tells you about association and not causation. So it may be that the people who are more likely to have pain and more likely to be less satisfied in their pain control are consuming more opioids, but it's an interesting association that I thought was important to point out. So I tried to pull up some data about what our current trends in opioid prescription are across the country for injuries. I think a common thing that we see both at our trauma center and in our community is rib fractures. So rib fractures, as you know, because of the pain associated and the impact they have on the pulmonary capacity of mostly older adults, as well as the rest of America, really can have an adverse impact on your health. And so we see that for people who come in with 4 unilateral rib fractures, the majority of providers will prescribe opioids, about 86% of providers. The average number of tabs is about 30 tabs. And just like with our other data, the range is very wide. On that initial, most people are not getting refills. So that may speak to the opportunities that we have for follow-up and changing sort of our practice patterns. And most importantly, I thought, is that there are a lot of non-opioid adjuncts that I'll talk about in a little bit, but only about 30% of providers prescribe people with rib fractures non-opioid pain medications. And those that do prescribe sort of on the number of about 40 tabs. The majority of injuries that come in related to trauma relate to musculoskeletal injuries. Isolated femoral shaft fractures is what this one study, 2018, that was published in the Journal of Orthopedic Trauma discussed. And they actually noted that there's a difference that we tend to prescribe people who are previously opioid exposed more tabs of opioids. And for whatever reason, the orthopedic surgeons were prescribing more than their non-orthopedic colleagues on the scale of 2-3 times more the morphine milligram equivalents for those injuries. As you can see, there's a wide variation in opioid prescribing, and this persists when you look at data in the ER and you're looking at people who are prescribing the ER. And high-intensity prescribers actually have patients who have higher rates of long-term opioid use. So the patterns of prescriptions by providers seems to really impact the continuation of opioid use in their patients. Opioid prescriptions are also noted to have adverse outcomes that are cyclic. So for instance, in older adults that are put on new opioid prescriptions, these adults are more likely to have increased falls and increased motor vehicle crashes. And so it sort of perpetuates this cycle. This may be a little hard for you guys to see on the screen. I apologize if it's too small. What this is a study that was done in China and published in the Journal of Bone and Joint Surgery. And they look at prescription medication use in patients who are non-operatively treated in the different areas of the body. And I want you to note that this is 10 pills, and that these 10 tabs are oxycodone 5 milligram equivalents. So patients who had non-operatively treated fractures of pretty much every body system, including multiple systems, and this includes the pelvis and the spine as well, in a multimodal system really only required less than 10 tabs of opioid narcotics, for the course of their treatment. This is another study. This was done in Massachusetts and published in 2019 in the Journal of Orthopedic Trauma. What they did was they looked at their orthopedic surgeons' use of opioids and prescriptions of opioids in a large database, and they came up with what they thought would be the most appropriate dose sort of prescription dose of opioids for the different body systems. I think what's nice here to note is that the numbers are relatively small. So if you recall, about 300 morphine milliequivalents is MMEs is equal to about 40 tabs of oxycodone. And occasionally people will need larger doses as refills, but as a total, people would have much lower doses than most people are probably used to seeing prescribed. And this is just to note that there are references for people that they could go look and say, okay, somebody's got a humerus fracture or a tibia fracture, what's sort of the appropriate dose for people? I think this is a nice reference point for that. I think something that's important is that opioid type is not as important as opioid quantity. I think specific opioids, take on different connotations when we talk about it in terms of prescription. But a nice study determined that really what it is that the discharge opioid quantity is really the thing that is related to persistent opioid use. All right. So trauma there, again, we go everywhere from, solid organ injuries that we have to operate on to musculoskeletal injuries, traumatic brain injuries. So again, it's a wide variety. So I can't talk about every single subset of injuries, but I did want to talk a little bit more specifically about the different adjuncts that we're starting to use more and more often in trauma. I think most of this information probably will be familiar to everybody because it pertains across all surgeries and all different reasons that you have pain. But acetaminophen obviously is the classic one that we are using much more often. It's opioid sparing, and it decreases on average about 20 milligrams morphine per day. But what you should know that it doesn't actually decrease in studies reported pain scores by patients. So the reason that's important is that these drugs that decrease your opioids but don't decrease your reported pain scores are probably better used and prescribed as continuous regimens. So if I have a person with pain related to rib fractures, I would schedule a dose of Tylenol over a length of time rather than saying to tell them to use that as needed. The same thing with gabapentinoids, and the most common one is gabapentin, obviously, that we use in the country, but pregabalin is also another one. Those also modestly decrease opioid use, and they do not affect pain scores. The thing I wanted to mention about gabapentin is that gabapentin is often used off-label for pain control. And the problem with that is that we're using it sort of as a replacement for opioids, and it becomes sedating. And there's a new interesting article that they looked at in Europe that was published in the British Medical Journal recently that linked gabapentin prescriptions with suicidal behaviors, unintentional overdoses, new injuries, motor vehicle incidents and offenses, as well as arrests for violent crimes and offenses. So that's not to say that gabapentin doesn't have a role specifically in neuropathic pain and treatment. I think it does. But I think we have to be careful, and that there probably will be, just as there was with opioids, a swinging of the pendulum back towards mean in terms of gabapentin use. Topical local anesthesia is another thing that we use, not super effective unless it's cutaneous or skin superficial analgesia. And then NSAIDs. Now, NSAIDs are something that we would rarely use in trauma for a very long time. And the reason was our orthopedic surgery colleagues really didn't like it. They had very good animal studies that demonstrated that they would impact fracture healing and union. And because of that, for the most part, the orthopedic community was resistant to using NSAIDs for a very long time. That, especially with the opioid, currently with sort of the change in the climate with opioid use and abuse across the country, they have revisited that. There are now some retrospective observational studies that look at this, and they believe that it's much safer and that it does not impact fracture healing and union. This is not high-level randomized controlled trial data, but this is pretty good moderate level data. And they now suggest that Orthopedic Trauma Association guidelines recommend the use of NSAIDs. So in general, NSAIDs are being much more used in adult trauma, and I think it's a really good thing because it really does decrease the amount of opioids that we use in our field. Celecoxib, or a selective COX-2 inhibitor, also is used, but less so than ibuprofen just because of the availability and cost. But it does help with platelet dysfunction in people who you're worried about bleeding. For instance, the people with your brain bleeds that may be more spinal, may have been stabilized over some time. Those are the people that you may consider with consultation with your neurosurgical colleagues. The one thing we caution absolutely against is benzodiazepines. And as most of you know, that when it's used in conjunction with opioids, really just increases your respiratory depression risk significantly and your overdose risk significantly. We have several inpatient adjuncts that we use at our trauma center. Neuraxial blocks, peripheral nerve blocks, epidurals, for example, are really important in thoracic injury, and we use it very often and liberally. Obviously, epidurals also have risk and are not as proven outside of the thoracic injury field. Ketamine and dexmedetomidine is something that we're also seeing more used by our anesthesia colleagues for people who have trouble with pain control. And obviously, because they're infusion, you have to be in an inpatient for those adjuncts. As the climate across the country, and it really hasn't come in Wisconsin yet, but as the climate changes for marijuana use, I think this is an important study to think about. So you might think that marijuana use, self-reported marijuana use, especially because marijuana has some analgesic properties, may decrease your opioid use over the long term, especially if people are using it in sort of a medical fashion with their other treatments as a multimodal approach. Unfortunately, what they've been finding in places where medical marijuana is available, that self-reported marijuana use during musculoskeletal injury recovery really increases the amount and duration of opioid use. So it's a little counterintuitive, but something that I think is important for everyone to know. The most important thing I want to cover, and I think this is probably the most important thing that I could tell you that's different, is that really our communication and education to our patients is really key in decreasing our opioid use and issues with pain control. So when this group in 2017 looked at their institution's data in terms of nurse discharge checklists, and the discharge letters or summaries that you provide to your patients, they found that in their institution they had a lower than expected rate of completion of these items, but that patients who have had these completed had the lowest pain severity and the best outcomes in terms of opioid use. So that's to say that there probably is a very important role in patient understanding of patient medications and its anticipated effects. It's really important to set expectations and goals. And also, I think there needs to be a clear plan for follow-up and tapering in all patients. And I think this is a nice thing to know, not just about trauma patients, which this study was done in, but also in all of the rest of our patients. I think communicating and educating our patients is really important in trying to fight this issue that we're having today in America. I'm going to talk a little bit about emergency general surgery, and a lot of this is very similar to the trauma. Again, emergency general surgery runs the gamut. And so I'm going to focus a little bit more on some of the more simpler cases that we might see higher volumes of. Those are our appendectomies and cholecystectomies. In general, about 92% of patients with opioid prescriptions after general surgery as a whole report that they have unused opioids. So that means that there are opioids around in their home and the community that are being unused. About 71% of the tablets are unused, about a mean of 20 per patient. And the problem is that, even though we hope that people are getting rid of them appropriately, they're not. Only about a quarter of people are getting rid of those that when they report it back, and only about 4% of those people who are disposing are using the recommended method of disposal. Again, this speaks to us really needing to, number one, cut down on the tablets that we're prescribing, as well as giving our patients the resources and information that are needed to dispose of those prescriptions in a safe manner. There's a wide variation. We just saw some of these for Wisconsin, so I'm not going to go over it too much, but even within institutions, there's a wide variation, just like in trauma, of prescription for post-surgical patients. And this is a nice study that looked at several different lower risk general surgery cases. I just want to focus on laparoscopic cholecystectomies. In general, these are the tabs down low that people were using. And these are the number of actual pills that they reported they used. Really, most people are in the 0 to 1 to 5 category. And most people do not exceed more than 15 tabs after surgery. In one study where they did a multimodal approach, so they specifically prescribed NSAIDs in addition to narcotic medications, patients only use, after laparoscopic appendectomy and cholecystectomy, they only use 2 pills. So that's only 10 milligrams of oxycodone after discharge. So I think we do have to start thinking about prescriptions for pain medications in a little different manner and really try to focus on the adjuncts. The adjuncts are very similar to trauma. There are, again, some low-level evidence that suggests that these other drugs such as gabapentinoids will decrease pain and decrease opioid use. I think a nice study is the use of a peripheral block, a tap block, intraoperatively in appendectomies. If there are surgeons on the line, laparoscopic tap blocks where you could target them intra-abdominally in surgery, you learn to do that pretty simply. And they do, in this, at least one study was demonstrated to decrease the amount of opioids the patient needed to have, and also actually decrease the length of stay for those patients in that study. NSAIDs also are good in this environment. The only caveat to this is that it's really just not as well studied in terms of bowel surgeries. There are risks to bowel anastomoses and fascial healing. There is also a question of relation to necrotizing soft tissue infections. For the most part, all these studies are small, and the majority of these studies demonstrate no difference at all. So for the most part, there needs to be further studies with NSAIDs, but the current data would suggest that NSAIDs are an important adjunct in general surgery and in emergency general surgery for the treatment of patients. And so I don't know if you wanted me to go through some of these questions or.
Yeah, we can. I don't think we need to belabor it because people who have joined us live are not going to have to answer the questions, but people who are watching this in the future, I'm sure would benefit from hearing about the questions.
Yeah, so just to go over, which of the following is most associated with persistent opioid use in the United States, and that's injury. Which of the following would be the most appropriate component of multimodal therapy for pain related to a humerus fracture in the outpatient setting? That would be an NSAID, which would be ibuprofen. Interesting thing is that there are some people who are doing studies of vitamin C and as related to pain control, and they are actually seeing some positive results related to that. But again, that's too experimental and too low-level evidence to really be using in your patients currently. And then finally, using a multimodal approach to pain, postoperative pain, what's the most likely number of oxycodone pills a patient will likely have to take after laparoscopic appendectomy and cholecystectomy? And as we discussed just shortly, it's just 1 to 2. So thank you guys very much for allowing me to give my presentation to you. I'd be happy to take any questions or if there's any questions or comments that anyone has.
Awesome. Stop sharing here. And then, yeah, feel free to use the chat function. I've also put in the chat function, and I will do it again here, a reminder for people who are listening live, a way to get your CME. If you're watching this in the future, you'll be taking the quiz at the end of the session. Angela Bessa is a nurse practitioner in Janesville, and she has joined us. Jessica Varnum, I see you on the line, and you've joined us in the past as well, so welcome back. Any questions? Yeah, before we get, before I start asking my questions. And again, feel free to use chat or just unmute yourself. All right, well, if anything comes up, let us know. I think all of this is so fascinating, but what I thought was, the most important thing, just like you said, is like this notion of education and setting expectations. And I've seen some data suggesting that most patients, like a clear majority of patients, when prescribed oxycodone or Vicodin, if you ask them if that, if they were prescribed an opioid, they frequently say no, right? Like the majority of patients don't actually know what opioids are. So even that simple thing of saying like, this prescription is an opioid is potentially an important way to engage. Like when you guys are doing your education around, discharging trauma patients, like what sort of tips and tricks do you have?
First thing, I think it has to be a systems-based approach. So I think one of the nice things that we have at UW is that the pharmacist goes over all the medications with our patients. And I don't think that's a universal practice everywhere. So I think that's an important thing. So I think when we talk to patients, in general, everyone's heard about opioids and the negative impacts of opioids. There are not a lot of people who come to us, the 30 million people who are injured in the United States. I think the majority of those people are not looking to get addicted to opioids. I think that's a fair statement. So I think if we give them the information, if we give them a plan, if we let them know this is a medication that you can get addicted to, and this is our taper plan, build in that plan to their care so that they don't have to just do it on their own. Because sometimes you could talk as much as you want to them at the inpatient setting, but when they come back to the office, they're still not quite clear. So there sometimes has to be multiple touch points for people. But if you could set up a system where people understand that they're getting prescribed opioids, just like you said, understand that there is a taper plan because this is a dangerous drug and that there are negative outcomes to it. Tell them what the impact of those drugs are and what the effects are. I once had a patient, I'll never forget this. She came back and she was prescribed a number of opioids for a major ventral hernia repair, and she was having a lot of pain. And over time she stopped it. But then she came back to me with opioid withdrawal symptoms, and she just didn't know what those were and what was going on. And so I think just describing how opioids impact them, how you come off of them, what are the different things you can expect when you start tapering them, and how to deal with all those things. And then really setting an expectation that if there are the issues or for continued follow-up is needed, that follow-up is available to them. I think that gives us sort of the best chance and best strategy at attacking the opioid epidemic that we're experiencing today.
Yeah, I mean, my experience around opioids in early training, right, was, I think my pattern was set on my first rotation as an intern at Harborview in Seattle, which is a huge trauma center. And our standard practice at the time was look how many pills they've taken over the past 24 hours, multiply that by 30 and send them out. Yeah. And I remember writing, for like 250 Dilaudid tablets. And I'm sure there are people walking around the Pacific Northwest now with opioid use disorders that are directly the result of my prescription practices as an intern. I mean, how could there not be, right? It's like 6% of patients and probably higher in the trauma population. But, I never felt like I was really, like the guidance was not send them out with the knowledge that they need to, have to understand what's going to happen if they become addicted and how to manage it if they find themselves withdrawing. It was send them out with a plan to minimize the number of calls they make back to us asking for pain medication, which I think is kind of like actually an imaginary thing. I mean, there's pretty good data now to suggest that you can drop the number of pills you prescribe by a lot and you don't get phone calls. And that's probably because people are going home and taking one or two.
Yeah, they just don't need it.
Yeah.
Right. So, I think that's a great point. I think the other thing we have to remember, just along the lines of it, is like, and it goes back to what I was saying before, you got to give them a stop plan. Most people don't know that they should stop. If you give them a prescription for 60, they think, the doctor wants me to take this medication, I should just finish it, just in case something goes wrong. So a lot of times people will come to me and be like, oh, I thought I was supposed to continue to take this medication. So when we write PRN pain, people don't understand what that is.
Yes.
They'll just continue to take it. So I think making sure that education around the cessation of the medication is also as vital.
Right, and particularly if you don't know if what you're taking is an opioid or an antibiotic or whatever, it says every 3 hours and like, there you go, right? I mean, such a huge, huge point. I think something that's changed in my practice as I've become aware of this is just asking my patients like how much pain medicine they've used or are using when they come back to clinic, and like really being regimented about that.
That's an interesting way.
And ask them, how many did you use? And I think, there was a big effort here that I know you're aware of, where we actually went and asked patients like how many pills they used after some common procedures, like lap chole and breasts.
That's right.
Some breast operations, and it turned out that that number was really, really low. And just knowing that our patients, you know, I think it was personal, right? It was our patients are taking very few, sort of allowed people to sort of dial back from the standard script for 30 to a standard script for 10, knowing that people are only going to take 2 regardless.
Yeah. I mean, you know, we get stuck, I think, we get stuck, you know, cognitively, right? We get stuck on the outliers because that's what pops out in our brain. So I think what we do get stuck on are like the phone calls of the people who have issues with pain control, right? And I think we extrapolate that data to everyone but when you really look at the data, it's much less. And I think that's an issue with how our cognitive biases really can hurt us with opioid prescriptions.
Thoughts from the field? Have you started doing tap blocks?
No.
Yeah.
I'm starting. But a lot of my minimally invasive or hernia colleagues have. So I think I just recently found this data. It's interesting. It's not very hard because you know where the plane is along, you know, semilunaire. So to inject that, it doesn't take a lot of time. You don't need an anesthesia specialist to like do an ultrasound guided externally. You can really almost see and get to that plane quite easily intraoperatively. And so it's really something that I'm strongly considering, mostly because it also has a really big role in our hernia repair patients. So I think it would, I think with knowing now that the data supports even improved outcomes in appendectomy patients, it's probably worth it. It may be even more worth it than like, you know, the extra 5 or 10 grams or milliliters of like local that I put in, you know, the dermis or the subcutaneous for our incisions.
I've started doing something, and I think anecdotally it seems to work. I'm not aware of a study, but you know, for my pediatric laparoscopic cases, what I do is I just under laparoscopic guidance, while I've got the camera in there, when I pull my ports out, I put a needle in just under the peritoneum and just do a little pre-peritoneal injection, because I think that a huge amount of the pain from laparoscopic sites is not the skin, right? It's the peritoneal disruption. And we often don't use ports for little kids, so we're kind of muscling things through the fascia, and I think you can see kind of bruising, and you see that if you do that a few times, like kids complain of pain more than if you just are kind of in and out. And so I've started doing that with Marcaine, and it seems to make a real difference, you know. And we send kids home with no opioids for basically anything at this point. Some of our big like NUS procedure, chest reconstruction, kids go home with a bit, but like we've sort of gotten rid of it altogether, and we are not, you know, inundated with angry phone calls from either children or their moms. We've got a comment from Jessica Varnum. Tap blocks work great, drastically reduced opioids in C-section patients.
Oh, fantastic.
That's really cool. So are you doing them, like you're doing them ultrasound guided after C-section? Like, can you just give us a brief description of how you actually go about doing that and how you learned to do it? Like who taught you?
I think I'm unmuted. Can you hear me?
Yeah.
Yes.
I don't do them myself. Actually, our anesthetists do them on all C-section patients, and they work very well. Really good pain control.
That's awesome. So like even like emergent C-sections and everything.
All of them. Yep.
Wow.
Especially general anesthesia if they don't have a spinal.
Yeah. And they're just like coming in at the end of the case, like drapes are down, and they come in with an ultrasound or something.
Yes, exactly. Yeah, and they do them ultrasound guided.
That's really cool. And Jessica, remind me where you're from.
Lancaster, Wisconsin.
Oh, cool.
I had a question about the variation in dosing that, you know, it seems like we found even for a single surgeon. So if you were going to prescribe for a patient, what factors do you consider when you're deciding how much to prescribe?
Yeah, I think the reason we have such variation now is that like we've sort of moved, but not everyone's caught up. So I think
Oh.
that high of like the 40, that's like the standard intern dose of like, post-operative pain. Okay, I'm going to prescribe you a 30 or 40 tab dose. And I think we've sort of moved and not everyone's sort of caught up. I think probably what we need to do at institutions, again, as on a systems level, is just to protocolize this. Because I think that if we allow, one surgeon to, and maybe, I think it's appropriate for providers to want some control and some nuance in decision making. I think that's true. But I do think that in general, if you look at most of the studies that relate to opioid use, especially in the trauma and the emergency general surgery population, the more protocolized and the less options you give people, the more likely you're going to stick to what you're actually seeing in terms of large populations and treat appropriately. So my suggestion would be take that out of the hands of the surgeons. Just say, and it is within their hands, right? Because they would decide as a group how much you would give. But I think, most practices, you should say, this is what we're going to give, and then just sort of stick to it rather than try to change around too much. And if you do find the people that you think are going to need more, I think probably what that's telling you is you probably need better post-operative follow-up so that you can refill the medication if needed and things like that, rather than to send them out long because I think you're going to need it for a long period of time.
Yeah, it seems to me like that's exactly right. Like the way to build an effective system is going to be for individual hospitals and physician groups to come up with these answers too, right? It's like, if the American College of Surgeons comes out and says, thou shalt not give more than 10 tabs for any given procedure, right? Like some people will say, okay, well, that's like a great recommendation. And I think, there are groups that are doing that. Open in Michigan is doing that. We at the Surgical Collaborative in Wisconsin are starting to try to develop guidelines and best practices and benchmark reports that sort of show you where you are versus other surgeons. And I think that that's valuable, right? Like knowing where you sit versus other people, but also like within your own group or practice saying like, this is going to be our standard. This is what we're going to teach the residents and the PAs. And then, within your own group, measure the effects. Like these are super easy internal QI projects that you can do that, have been done here that have been really fruitful in terms of understanding what your own patients want and need, which may differ from place to place, right? And socioeconomic factors and your population, but
yeah, I mean, for example, on our emergency general surgery service, we again just started that. So we've protocolized the amount of pain medications for our major index cases that patients will be prescribed when they leave. Just flat number. So
what was your process for doing that? Like how did you kind
basically
of
it was the same as what the quality improvement projects you were talking about. Our most of what we do, the majority of what we do are is general surgery. We do see some of the complex abdominal issues and people who need long-term care and follow-up, but a lot of them is bread and butter general surgery. So that information is available everywhere. Whether it's through the Michigan Collaborative, through the multiple studies that they publish.
Right.
The most likely dosage that people will require. So we just stuck with those and see how it goes.
Yeah, and then you're kind of tracking, making sure.
That's right.
Are people calling back saying this is not working for me? I need more. And if not, I guess then
we're good. That's good.
Or
you can even
inch it down as time goes on.
Well, it's pretty low, right?
Yeah.
We're really talking about 5 tabs.
That's great. Wow.
So 5-10 tabs. So.
All right. Angela from Down Janesville says, one of the things I've educated my patients about is that a pain rating of 0 after surgery or trauma is unrealistic. Using APAP or Tylenol and NSAIDs and cold compresses may be enough to lower the pain level without completely eliminating it with high doses of narcotics that have many side effects.
Yeah, that's absolutely right. I mean, I think, again, setting that expectation that, narcotic pain medications are not going to take away your pain completely. That our goal for pain control is a target where your functional, abilities are not impaired. So really around a pain score of 6 is where you want to try to get most people. So I think that's absolutely important, and it's critical, making sure that the goals are the same.
Yeah, and she went on to say, if pain decreases from 8 to 5, that's acceptable to many patients. And I think that's right. I remember right as we were sort of starting this opioid study work, there was an article in the New York Times by a woman, American writer, who had had a hysterectomy in Germany. And she was like, yeah, they gave me no opioids. They gave me Tylenol. And then after I'd been on the Tylenol for about 48 hours, they said, oh, we've got to start weaning you off this Tylenol. We don't want you to like develop a Tylenol dependence. And she said it would just like, you know, they said like lay in bed, have a cup of tea, like don't get up and move around. And it's obviously that's not the way we practice here. I think we're, you know, we've sort of like been, you know, and this is, I mean, obviously well described, the effect of like making pain the sixth vital sign and trying to get everyone to zero is a huge effect, but there's a huge cultural element here. I mean, you know, absolutely. Like there's a sort of cultural expectation of pain-free surgery and having to reset that and be like, you know what, this is going to hurt, but like, we'll keep it manageable, it'll get better over time.
Yeah, I mean, we, you know, if you look at these numbers worldwide, you just do not see the same prescribing practices, not just in like, we're talking about other first world countries that, you know, really have socioeconomic status is very similar to ours, maybe in terms of medical care, even better than ours.
Yeah.
And we just don't see the same practice. So I think, yeah, you're right that there is definitely a cultural element to all this.
Yeah. Well, I saw some encouraging news that the opioid overdose rate has started to tick down for the first time since 1990. So I think folks are out there making a difference. And,
yeah, that's great.
Anyway, this has been awesome as always. Thank you so much for joining us. I've got a quick little series of closing slides here somewhere. So coming up next month, pre-hospital. Coming up in September, primary care. We're getting close to the end, but all of these sessions are going to be available for you online to get opioid credit. Tell your friends, tell your colleagues. Hopefully this has been a good resource for all of you. We talked a little bit about the work of the Surgical Collaborative of Wisconsin at the beginning, and we do have a very active opioid use and opioid reduction effort as through the Surgical Collaborative of Wisconsin. I encourage you to take a look at that, particularly if you're a surgeon in the state of Wisconsin. It's going to be very tailor-made content for you, and if you find that it is not adequately tailor-made, let us know and we will tailor-make it. We also run a number of other series like this under the Project Echo banner. Randy Brown in the Department of Family Medicine runs one for opioid dependence. We run one for pediatric emergency care and another one for surgical indications and continuity in kids. That's for primary care docs who take care of kids who need operations, but really anyone's welcome to any of these. These are all on third Thursdays. Pediatric emergency care is at 2 o'clock and surgical indications is at 4. We love having more people there. And I run a podcast. If you can't get enough of my voice, you can find 74 and growing episodes of the podcast at surgery.wisc.edu/podcast. And our hour is up, but any final questions or comments? Thank you for joining us. All right, everyone, thanks so much. We hope to see you again here soon. Take care.